Hello friends, I'm Dr. Saurabh Patwardhan from phacotraining.org.in, and along with me we have Dr. Deepak Meghur, and this is the video of the month. This video was submitted by Dr. Hassan Uleri from Morocco, and it's a very interesting video of phacoemulsification in case of a brown heart cataract, and he wants us to comment and give some reviews about his video. So over to Dr. Deepak, who will play the video and will, along with that, will give our reviews. So this is a brunescent cataract. So I think before we start, as we see, Dr. Deepak, you can give some of your pearls when you approach such case in your practice.
See, in a hard cataract, there are a couple of concerns for me when I'm planning a surgery in such hard cataracts. One obviously would be to protect the corneal endothelium because the nucleus fragments which are there, they're quite hard and dense, and we are also going to consume a lot of energy in these situations. So protecting or preserving the corneal endothelial health is a primary concern. And also I'll be concerned about the wound burn, which is also more likely to happen because we consume more energy. Of course, when you're using torsional, it won't be there. And we need to have a systematic plan on how we are going to divide the nucleus, because dividing the nucleus is going to be testing our skill here and also going to take some time, unlike our regular cases. To aid in that, I would always like to make a slightly bigger rhexis, and to ensure deeper burying of my phaco tip, I would like to expose the tip slightly longer than usual. The choice of nucleus division technique could be anything. It could be a direct chop or a stop and chop or a 4-quadrant technique. Only thing I would ensure that the plane of emulsification of the fragment has to be much more posterior, because that is what is detrimental to the corneal endothelium. And also, as we see here, he's trying to do a slightly bigger axis, which is a right way to go about, because it eases the way we manage the nucleus. And the choice of nucleotomy could be anything. If I'm doing a direct chop, I'd like to do a deeper trench before doing a direct chop. And what would be your few tips, Saurabh, in such situation?
And with this rhexis, I just want to see that in the subincisional area, he's struggling a bit. I think that is the area where many surgeons struggle. So what I generally do is I use the cystitome. So I go sometimes from the side port, and then for the subincisional, I can use that. Or we can use a microcapsule rhexis to take care of this subincisional part, because of course he did it well, but I think he was having some trouble while negotiating that particular part. So I think in such cases, we don't want rhexis to be extended, because that's going to jeopardize our plan. And of course, hydrodissection, I will do very little, very minimal, because here the nucleus is dense and it will rotate very easily. And I don't want posterior capsule, the fluid should not be trapped behind it. So very minimal hydro is good, and he can rotate it well. So my plan for these cases, you already pointed out, my plan usually is to chop entire nucleus into at least 6 pieces in the bag itself before I start with the quadrant tumor. And I think here the main issue which I found on reviewing is that whenever he was trying to do the phaco, the globe was getting pushed down. And when the globe gets pushed down, two things happen. Is that one is that your visualization is hampered, and then you tend to do phacoemulsification in slightly superficial plane. I think the deep trench which he's making is quite good here.
Yeah, just a quick point. Just let us go back and see. I think there is some amount of pushing going on to the nucleus, as we can see here. Right. Because maybe I would like to use still more power and slightly widen the groove, so that you're not inducing any stress on the zonules. He's supporting well the nucleus actually with the left hand. But when you're trying to go in trench, the amount of energy might not be still sufficient. Maybe we could have used a slightly higher amount of energy just to reduce the amount of stress which is being put on it. But he did a wonderful job in doing a very deep trench. Deep trenching, as you were pointing out, is extremely important because the lateral separation becomes very easy. You can continue, Saurabh.
Now, once the division is made, see how he is waiting patiently to divide the last fiber. And I think he has done it well, because many times it stays stuck sometimes and then hampers in the further divisions. Now he's doing, I think he's using a blunt tip chopper and doing a horizontal chop. Now he just waited here. Now I generally replenish the viscoelastic in between for such hard cataracts, because I think endothelium is has to be protected for such cases. And now you can see the pushing down of the globe. So what the surgeon has to do is use his left hand to pull back the globe to the center, because now you can see that the phaco trip itself is getting withdrawn a bit. The phaco plane, as Deepak was mentioning, is superficial, not deep. And that's all this thing is happening because the visualization of the surgeon is hampered. Yes, Deepak?
Yeah, I think, first of all, this is happening because a surgeon is not aware of this thing. He's so focused on the nucleus consumption. The visualization is happening in the peripheral part of his visual field, but he's so focused on removing it that that part has escaped his attention. So what is happening is, because there is a slightly lack of stereopsis because the peripheral vision has come into play, he's not aware that he's slightly come superficial.
Yes.
And because the globe has turned, and actually can see the BSS from the sleeve hole is actually coming out here.
Yeah.
It is the hole is actually is coming out, like it's so near to the exiting of the wound. So
Yeah.
that is one thing. It's happening because he's very much focused on concentrating on the nucleus part, rather than all these things have escaped his attention.
Correct. So now for the second half, as I said, for my protocol is that I always divide it first, so as to avoid this struggle of separating the same second heminucleus, because you don't have support now.
Yeah.
And then with these sticky nuclei, you always tend to struggle for dividing it completely.
Okay, I think one of the reasons why he's not able to get the perfect horizontal chop or separating would be he's not able to get a deep bury into the nucleus, because the sleeve is exposed slightly lesser. The tip is exposed less because sleeve is almost intruding it. And second thing, because the bag is empty, we don't have the support of the other nuclear fragments which can tolerate your movement, because the moment you try to chop, it's going to slip here.
Correct.
So it's going to be, and he's trying a horizontal chop. That's the one which is to be tried here. He's doing it all right, but because the posterior plate or leathery fibers are so strong, he's not able to achieve it. If he had exposed it a little bit more, things would have been slightly more easier for him. The struggle is going to continue. He has chopped the superficial half of it, but the bottom part is still connected. So what I would have done here would be, I would have just tilted the fragment a little bit, exposed the posterior plate anteriorly, and phacoed that area which are hold the base. Phaco the base of the fragments which is actually holding it. Once you phaco a little bit, all the fragments become loose, separated, and then you can individually emulsify them.
Yeah, I think again here the attention to endothelium is not being provided. So I would like to again replenish visco, make the chamber deep, push the nucleus pieces down a bit, center the globe, and then go ahead.
Yeah.
So this is very risky. He's, I think, coming superficially because he wants to stay away from the posterior capsule. So I think that's the, the instinct that anti-segment surgeons have. But with that, you have to keep in mind the endothelium has to be well protected.
I think just idea is spot on. He is a little bit more worried about posterior capsule, probably. That is maybe playing into his subconscious mind. That's the reason why he has pulled the tip a little bit more anteriorly, and he's working very close to the wound. Actually, the probe is almost at the end of getting out.
Yes.
I think the simplest thing would be, there is no urgency for us to finish the case fast.
Yeah.
Every fragment later, you just go in, push in viscoelastic. When you push in viscoelastic, you get a time to analyze, think, and just take a break. When you pause, you just get your all senses back, and maybe you can analyze, maybe I'm not seeing well. You get that extra second to think and plan out well. There's no harm in coming out, putting viscoelastic, and then proceeding with the surgery. As you all repeatedly told, that you would have always gone in with a second bout or third bout of viscoelastic injection. Apart from replenishing the viscoelastic inside the eye, it would also give us an opportunity to cool us a little bit, get our senses back and plan it out a little bit. The viscoelastic also would have pushed the nucleus down into the bag again. And again, we would have worked more posteriorly, I should say. So
Correct.
there is no take home message is there's no hurry to, finish the emulsification in a single shot. So he's trying to do it in a single shot. So it's all right, but we could take this break. And he has done wonderfully well. He could finish everything without any complications and everything. I'm not sure what viscoelastic he has used, but I think it is quite good enough to protect the endothelium.
Now injecting the IOL, I think is a 4 haptic IOL, and you could see that the trailing haptic got stuck. So this is something we have to be little bit careful about whenever we are injecting IOL. Sometimes it may break while doing that. Apart from that, I think he has got excellent skills. Only I think the few tips that we thought what we have given will improve the predictability and the clinical outcomes also.
I think thank you, Dr. Hassan, for submitting your video, and we appreciate your inquisitiveness to better your surgery and all. These were just some of our observations which we found would help you to tackle the same tough case in a better way in the near future cases. I think the two take-home message would be ensure that you're always seeing well, ensure that the globe is not pushed down, it is in the center of your visual field. That ensures that you're seeing well. And most of the things which you did was quite right. You got a bigger axis, you did a good hydrodissection. The nucleus division of the first half was quite good. But only the emulsification of the fragments, you're slightly more anterior. I think that you need to take a little bit of a caution for your next, otherwise you did fine.
Yeah, I think in any step, if you feel that you have to take more efforts, or you feel that there is a certain amount of uncertainty, you have to think over that step. Are you doing something which you should not be doing, or if anyone else is doing something effortlessly? So if someone is doing the same step effortlessly, you try to copy that step. So I think that is my take home message for you. I think wonderful, you have got excellent skills. Few steps I would, from my point of view, can be improved further, so that you can get much better outcomes. I'm sure you are already getting good outcomes with this kind of skill, and this might further help your practice.
So thank you, Dr. Hassan, and wish you all the best.
Thank you. And for all other colleagues who are watching this video, I'm sure like we also learned from our own videos by seeing many other surgeons operating. And if you have, you feel that if you can send us your videos, we can give you certain tips which might be helpful for you. And this will also help our colleagues also to learn better. So we are looking forward to more videos from you.
Thank you so much for your attention.